are you? I'm Dr. Daniele from Argentina. I will present our next session. Could cancer patients and survivors benefit from better prevention programs? I will introduce our next speaker. She is Dr. Blaes. He's oncology and hematology from the Division of Hematology and Oncology at the University of Minnesota. She is the section head of medical oncology between this division and is the director of Cancer Survivorship Service and Translational Research. She's gonna talk about how to organize a long-term survivorship program. Please, Anne, it's a pleasure listening to you.
Great. Thank you very much for having me. I really appreciate this opportunity to talk about this. I think, first of all, it's been an incredible meeting. I've really enjoyed hearing all the presentations. And as we think about putting together the talks we've heard, I'm going to challenge you to think about how do we continue to take care of all of these cancer survivors. I have no disclosures. I am the immediate past chair of the American Society of Clinical Oncology's Cancer Survivorship Committee, so you will hear me reference some of the work we've been doing there. So I don't need to tell this audience, but I think it's good to step back and look at the number of cancer survivors, where we're at and where we're headed. What you can see is in 2016, it was estimated we had approximately 15 million cancer survivors. This is expected to increase to about 26 million by 2040. And these are numbers just from the US, knowing that I'm talking to an international audience, I'll show a bit of both. But this is growing internationally as well. What I want you to think about is in the green and purple and turquoise bars, these are all individuals over the age of 65. So thinking that not only do we have a growing number of cancer survivors, we have an aging population where they're also at risk for cardiovascular disease. In taking care of all of these patients, it's important to think about the projection of visits. So Deb Mayer and colleagues at the University of North Carolina looked at some of this projection. And if you look actually at if there are 5,000 new patients seen in a clinic and you assume that half of them are going to have a long-term follow-up, by 10 years out, actually, that quickly translates into over 60,000 follow-up visits. Similarly, if you have 10,000 patients seen in a healthcare system, by 10 years out, that's over 120,000 follow-up visits. If we assume that after 5 years, they're being seen annually, it's a huge number, and it comes back to how do we take care of these individuals? We have a larger number of primary care providers compared to oncologists. These are some numbers from about a decade ago in oncology. But even with that and with adjustments with mid-level providers, ASCO has still really estimated that there will be a shortage of more than 1,500 oncologists in 2025, so not too long from now. All of us are aware that when you take care of cancer survivors, they're not all the same. Some are at high risk for complications. Some have very few complications or risk for cardiac late effects. Some of this is related to their pre-existing medical conditions, the types of cancer treatments that they had, and whether or not they developed complications. Some of these are unmodifiable risk factors such as genetic risk, age and gender, and also lifestyle factors. So taking into account our aging population, these other factors also need to be taken into consideration. So when we think about cancer survivors, the NCI today defines a cancer survivor as anybody from the time of diagnosis through the trajectory of their life. This definition has really evolved over time to think about it as the cancer care trajectory. Part of that is having patients really understand what kind of treatment they had and follow-up care. But it's also about not just a care plan, but it's about connecting patients to services, programs, and wellness. So making sure that they are aware of cardiac risk, for example, after their cancer treatment, getting them connected with cancer rehabilitation, and staying connected with primary care. So how do you organize a long-term follow-up clinic? Who should be in it? What's the right model to use? First off, I would argue you need to know your patient population. This is a Models of Cancer Survivorship Care that was produced by Larissa Nekledoff. And at the top of the screen, you can see a shared care model. A shared care model may be if you have a clinic with a number of patients living with cancer or on chronic immunotherapy or chronic TKIs for their CML, they're always going to have some involvement with their oncologist, but continuing to have them see primary care in a shared care model may be the appropriate model for them, where they're continuing to get preventative care, but are also seeing their oncologist, as opposed to somebody who went through their treatment and had a curative intent, where a long-term follow-up clinic and being seen annually may be a more appropriate model, where they're seen in a consultative fashion. They need to have a primary care provider, but they're seen on an intermittent basis for risk management, stratification, and to make sure that they're getting appropriate care. More recently, as an oncology community, we've been challenged to think about a risk stratification type of approach. Knowing that not all patients are the same, we think about those who are low risk, such as a patient who had colon cancer and had surgical resection alone, may be sufficiently treated by just their primary care provider. On the flip side, a high-risk patient may need to continue with an oncogeneralist or a primary care provider with some type of survivorship experience. Low risk and high risk may take into consideration whether or not they received high or low doses of alkylating therapies, radiation treatment, stem cell transplantation, whether they've had late effects from the treatment, as well as the age they were treated at. Our pediatrics and young adult populations continue to have ongoing issues as they age, and thinking about how to include them in the care model is important. They may need ongoing annual follow-up in a long-term follow-up clinic. And I would also mention that there's unique patient populations. So we mentioned pediatric and AYA and bone marrow transplantation, but some patients live in a rural area very far from actually a cancer center where they may actually have this survivorship expertise. So some groups have tried different models of care. So mobile clinics, this was out of Texas, where mobile clinics went across the state to do screenings and risk stratification. There's mobile applications that have been used, such as these BMT transplant guidelines. And more recently, we've had the explosion of telehealth with COVID. I think for those of us working in survivorship, we've been begging for survivorship care and telehealth actually for a long time. And it's been exciting to see this happen in a really quick fashion with COVID. Secondly, it's important to know your providers, to think about, are there champions interested in cancer survivorship? This might be nurse practitioners, PAs, it may be a cancer rehabilitation physician who's really interested in promoting the wellness and care of cancer survivors. Most primary care providers want to be involved in survivorship care. About 3/4 of them say they are already doing this. About 3/4 also express confidence in providing follow-up care, but they also want more information on it. And if you look actually at what kind of knowledge they have in a survey of family practitioners about screening for childhood cancer survivors, only about 10 to 15% could answer a vignette correctly on what type of appropriate cardiac surveillance or breast cancer surveillance they should be having. More recently, we conducted a survey of providers on breast cancer screening in the state of Minnesota. We gave them a case vignette of Hodgkin survivors treated with mantle radiation, and only approximately 1/3 could actually answer the vignette correctly according to the guidelines that these patients should be screened with both breast MRI and mammogram. Internationally, England and Northern Ireland have developed and tested personalized care follow-up care pathways. Australia has this in development. ASCO's Cancer Survivorship Committee, we've been honored to have some representatives from England come and work with us, and currently have a member from Australia on the team. This National Cancer Survivorship Initiative is really built so that all patients see primary care with follow-up care pathways to help self-manage post-cancer needs and surveillance tests. There's only a subset of them that are seen in a long-term follow-up clinic. So thinking back to that risk stratification, this is really thinking that all those patients are seeing primary care with a small subset of them seeing a long-term follow-up clinic. Shared care is given where there's complex management, but there's some key principles in this. Patients need to be able to triage based on risk of recurrence, subsequent cancers, or late effects. Patients need to be able to identify issues. Ideally, this might be done in a EPROs type of setting. Remote monitoring needs to be implemented so that patients who are having exacerbations of cancer-related symptoms or late effects can be identified, and really engaging patients to support self-management and reducing face-to-face clinic visits may be what's ultimately needed. And as I mentioned, these are being tested in England and Northern Ireland, as well as in Australia currently. It's important also to know your requirements and barriers when thinking about implementing a survivorship program. For example, in the United States, a number of programs are cancer centers. Part of that is having a Commission on Cancer Accreditation, which requires that patients with curative intent treatment have a treatment summary and care plan within 12 months of completing their cancer diagnosis. This requirement more recently has been adjusted to really reflect that there needs to be a survivorship care team and a plan on how to connect patients to services. NAPBC still requires the treatment summary and care plan. It's important to know what are the requirements for your institution. How do you have a team to approach these patients? And I would also argue, is pediatrics at your site? If they are at a pediatric hospital, how do you actually facilitate and get them into the adult hospital where they're not lost to follow-up somewhere? There may be patient-level barriers, such as a resistance to leave the oncology clinic. There may be clinician-level barriers. It's great for us to see long-term survivors that are doing well. I might not want them to transition to their primary care provider. And sometimes there's health system-level barriers suggesting one way or the other how to triage patients or implement care. And then I wanted to mention a few other key things. So I mentioned to you, I work very closely with the American Society of Clinical Oncology, and I encourage you to look at the Survivorship Compendium, ASCO.org. You can look up Survivorship Compendium. Our team really has worked recently to update the Survivorship Compendium, and there's great resources in there on how to build a survivorship clinic, how do you get patient engagement, some of these factors that we're talking about. So I encourage you to take a look at that. There are a number of organizations, both within the US and internationally, that have guidelines on follow-up care and what are some of these key essential elements. Remembering that it's not just about the oncologist and primary care provider, but it's integrating our social work and cancer rehabilitation, our cardio-oncologists into that care. I think communication is key beyond cardiology and oncology. It's important to be accessible, be flexible, and engage primary care. And I really think that it's important, we're going to need to be novel thinking about technology. How can we implement some of this survivorship care into the electronic medical record? How can we use our chemotherapy order sets that are embedded right in the medical system? So whether it's Epic you're using or Cerner or one of the other electronic systems, how can we risk stratify patients right off of those templates? I know in one of the earlier sessions, Dr. Dent asked about cardiac risk assessment for patients, and can we build those right into our care, both during chemotherapy, but even in the survivorship period? I think using our electronic record, on top of that, being novel with some of the things we're all wearing and carrying around. I think about our monitoring our heart rate and our oxygen level, and in some situations, blood pressure, and how do you implement that into the medical record? I wanted to tell you briefly about the long-term follow-up clinic in Minnesota. So really, survivorship care begins with the time of diagnosis. All patients going through their treatment, they work with their oncologist, but also nurse practitioners and physician's assistants, really at that time assessing sort of toxicity to therapy. Our long-term survivors that are more than 5 years out really are risk stratified. Our pediatric patients are seen by a pediatric oncologist, Kareem Sadak, a nurse practitioner, and a med-peds physician. When they're under 21, so really a pediatric, they are seen in our pediatric hospital. And once they are over 21, they're actually seen in our adult clinic, but really by the same group of providers. We have a BMT clinic, and then I oversee our adult clinic, really with some champions in head and neck, women's cancers, and lymphoma. But I mentioned to you the importance of having a champion We have a large number of sarcoma survivors who receive high doses of anthracycline, but I've really struggled with how to engage them in our long-term follow-up clinic. And I use that just as an example that some of the success is having champions to help support this. And then really using the resources, social work, psycho-oncology, cancer rehabilitation, cardio-oncology to help take care of patients, because it's not just about how do we make sure that their cancer is gone, but it's making sure that they're having an ideal weight, that they're coping well, that they're exercising, that they know what their screening tests are, and are they at higher risk for cardiovascular disease, for example. We've seen by many of the recent publications, such as that in Lancet, that actually in a lot of diseases, actually cancer death is going down and is almost being surpassed by cardiovascular death. So in summary, we know there are a growing number of cancer survivors. There's an important role for the continued implementation of long-term follow-up care, and in some cases, long-term follow-up clinics, really in a risk stratified approach. And there's a need to incorporate the primary care provider into cancer care, knowing that this role will vary over time. And I would encourage all of you to think about technology and how can we best use that to enhance our care to risk stratified patients. And finally, I wanted to let you know Minnesota is hosting a Cancer Center Survivorship Research Forum next spring on innovations in survivorship care delivery, really thinking about how can you use technology, how do we enhance this care, not just with a long-term follow-up clinic, but using our other partners. Thank you.
Thank you very much, Dr. Blaes, and this understanding presentation. I want to introduce Dr. Joseph Carver, our chairman. Joseph, are you there?
Here, finally, I am here. Thank you.
Thank you very much. I want to move forward with our next talk. I want to introduce Dr. Joerg Herrmann.
Sure.
Joerg Herrmann graduated from Ruhr University in Bochum, Germany, and completed his internal medicine residence and cardiovascular disease and interventional cardiology fellowship at the Mayo Clinic in Rochester. He is a professor of medicine and the director of the Cardio-oncology clinic at Mayo Clinic. He also served as an associated editor from several journals. He's gonna to talk to us about cardio-oncology in the COVID pandemic, what we need to know. Joerg, it's a pleasure to present you, and welcome.
Thank you so much, Andres. I hope we've overcome our technical difficulties. Let me know if there are any. But I want to reiterate what's been said before. Having been attendee for the up to this point of this virtual Cardio-oncology Summit, it has been fantastic. So kudos to the organizers, deepest thanks. And I also thought it was really fantastic that you grouped the last two talks to be from Minnesota, and particularly an honor to present the last talk on the COVID pandemic, which is the reason we're meeting just virtually today and not in person. So I think we're all familiar with the global tally of COVID-19. We've seen 26 million cases. We've seen now over 1 million deaths by now, end of this month and beginning of October. And there is even a linear correlation between these two figures. Just the threshold or the set point differs across different countries, as illustrated here. It's very pertinent, and this was recognized from the beginning, that there is an age gradient, and it's an exponential correlation. Over the age of 60, the mortality rate once infected and developing COVID-19 can be extraordinarily high. And what was recognized early on in studies from China, and there was a first wave of publications when these mortality rates were really high, they've gone down since then, that cardiovascular disease and cardiovascular risk factors are really pertinent risk factors for mortality in COVID-19 patients. These patients have a higher risk. And the second wave of publication was also recognized that cancer patients have a higher risk of mortality. So combining these two aspects would then lead to the conclusion that cardio-oncology patients would be at the highest risk among all patients once infected with the virus and developing COVID-19. Meta-analyses results are available by now. This is the status end of July, indicating that cancer patients have a threefold higher mortality rate when they develop COVID-19. And also, they have a nearly fourfold higher risk of developing a severe or critical course of this very disease. These are data from a New York hospital system, and as you know, New York City was heavily affected early on in the United States. And what I think this study really nicely outlined is that the higher mortality in cancer patients is in fact a matter of comorbidity. You can see that to the right-hand side, the patients who did not survive, they were older, but also, importantly, they had more cardiovascular risk factor and cardiovascular disease. So this cardio-oncology aspect emerges again. Interestingly, there was a trend that patients with active cancer and metastases would also have a higher risk towards mortality. And there was no difference in the types of cancer therapies received. And other studies have shown too that chemotherapy is not necessarily a risk factor for mortality in this particular setting. There is some conflicting data on immunotherapy, whether this increases the risk of mortality in cancer patients once infected with SARS-CoV-2. Now, this is from the Memorial Sloan Kettering in New York, showing that cancer patients with COVID-19 who have a more severe or critical course of their disease have a higher level of interleukin-6, a higher level of D-dimers, and a higher level of troponin I. And why is that pertinent? I think it's pertinent because it echoes so well the seminal findings from this very early seminal study out of China, identifying the risk factors for mortality and outlining that these three biomarkers are really predictors of mortality, in particular at D-dimer level. But they also show that there are three aspects to this entire disease spectrum: that inflammation, thrombosis, and myocardial injury and their gravity impacts the gravity of the outcomes of COVID-19. And this is important also for our cardio-oncology patients. There are genomic and metabolic differences that predispose them to inflammation. Again, immune therapies might contribute to it. Then cancer patients already have a higher risk of thrombosis. And then a number of chemotherapeutics are really toxic to the endothelium, and that adds to the endothelial injury that the SARS-CoV-2 virus induces. And then cancer patients, they see a decline in their cardiovascular reserve with cancer therapy. And then also a number of cancer therapies have the predisposition to cause cardiotoxicity. So what do we do in the cardio-oncology population, or should we do ideally? I think we should really aim to optimize cardiovascular risk factors and cardiovascular disease. That's been the theme of this conference and is always for cardio-oncology. But here we really need to be careful about those who are elderly and male, and patients with hematological malignancies. Several studies have indicated that consistently that this is the group of cancer patients that face the highest risk. Second up are lung cancer patients, and that we need to adjust then cardiovascular screening as well to be really attentive to the changing environment. And this has been the focus of this ICOS consensus statement on COVID-19 and cardio-oncology. We reflected on the different stages of a viral pandemic, the peak, the pre, the peak, and the post, and also reiterated the same kind of timeline, the pre, the peak, and the post in terms of cancer therapy, and that we should not forget paying attention to the cardiovascular disease aspects and addressing them, although this needs to be done in the broader context. And we suggested that it should be stratified by the cardiovascular disease-related risk, by the cancer disease-related risk, and by the COVID-19-related risk. So you see the distinction between high and low risk. So high risk CVD and high risk cancer scenarios do need treatment, urgent treatment. But if it's in a high risk environment, especially then very carefully conducted. And in general, less exposure here is more. In fact, we reiterated as the first general recommendation that, I mean, protection is the very best thing that we can do for these patients, and sort of keeping them out of the hospital if we can. If they have to have medical care, they have to have medical care. But everything else could be shifted to non-face-to-face encounters, and we outlined that there are these day and age, and Anne mentioned it so well, in the telemedicine era now, there are various options. We also reiterated that the cardiac imaging shouldn't be confined to only what's critical and really clinically necessary. And there are some very specific recommendations, but that's the bottom line. And you really want to choose the imaging technique that answers your clinical question. Maybe try to combine, have an Amazon approach, a one-stop approach, if you will. If you can find a technique that will address multiple questions at the same time, such as a chest CT, for instance, addressing the pulmonary aspect, as well as some cardiovascular disease aspects. And then maybe the biggest shift of all what we've proposed is the cardiac biomarker-based approach. Dan Lennon already mentioned this earlier in our meeting, that this is a shift that shines through this document. But we also want to emphasize that this is in combination with accurate symptom assessment. So this is the final grid we get to then, is that in combination, you would come to the conclusion that if a patient is symptomatic, they do need to be seen, they do need to be evaluated. Also, if both cardiac troponin T as well as the natriuretic peptides are abnormal, they also need to be evaluated further. Now, if both are normal, no symptoms, you're really in the green and can continue with the surveillance mode. And here, I just want to add that really weighing in on the high negative predictive values of cardiac biomarkers. So as long as they're really in the green, there is a low chance that patients have some serious disease evolution. If one of these biomarkers is abnormal, then the next step would be to repeat it and then take it in either direction, depending on the subsequent results. So how do we put this together? Cancer patients in the COVID-19 era, before therapy, we would recommend that they do get routine cardiac function assessment if they have high-risk features, and those would be meeting the ASCO guidelines. For instance, if patients undergoing anthracycline or HER2-based therapy, they also get a baseline cardiac biomarker panel. And then during therapy, we recommend that cardiac biomarkers be repeated with each cycle as feasible, and if abnormal or symptoms evolve, symptoms of heart failure, then to pursue cardiac imaging. Also, if patients reach the higher cumulative dose range of anthracyclines. For HER2-directed therapy, similar recommendations, cardiac biomarker with each cycle, and if symptoms or abnormalities, then to proceed with imaging and react accordingly if you find symptomatic or clinical cardiac dysfunction. After therapy, for survivors, we felt that routine cardiovascular imaging should be postponed until COVID-19 restrictions are lifted or adjusted. And reiterating what Anne just had said as far as the symptom awareness, the optimal management of these patients, and occasional cardiac biomarker assessment, and particularly if there are any red flags, orange flags, or any flags whatsoever, these patients should not fall off the radar. So in summary, cardio-oncology during the COVID-19 pandemic, what we need to know. I think number one, cancer patients are at high risk for worse COVID-19 outcomes, including mortality, especially heme and lung malignancies. Number two, increased mortality risk in COVID-19 cancer patients is a matter of comorbidity, cardiovascular risk factors, and cardiovascular disease to mention. So number three, then cardio-oncology patients present the highest risk group for COVID-19. And protection really is key. Protection from infection, the single best intervention, while not foregoing necessary and life-saving therapies. And number five, cardio-oncology care to emphasize optimal control of cardiovascular risk factors and cardiovascular disease, especially if high risk, and to focus on a biomarker-based surveillance if we can. And so with this, I thank everyone for attending. I think that might be the best conclusion slide, because it also thanks everyone for everything that's being done in this area. And I'm looking forward to the discussion.
Joerg, thank you for putting this into perspective and being practical as always. So I have a question: is the acute phase being over and getting back a little bit more towards being normal? What have we learned, and how do you think it's going to change what we do and how we follow patients going forward?
Yeah, I think I mean, it's a general question, right? For so many aspects, as we get used to a different style and also get experience with it. If we really shift towards a more cardio biomarker-based approach, I mean, we have a real chance to see how this compares to an imaging approach if it has the same safety net, if you will, and then maintaining it. I think we can only benefit from this. We can always go back to the other mode, and we should, if we find that this is not equally efficacious. I mean, we should utilize what's been established. And Anne already pointed out the telemedicine. It's, I mean, unique opportunity in the survivorship era to move connected care models, to move remote monitoring models forward. Those would be my initial thoughts. I don't know if, Joe, what do you think, or Anne or Andre, what are your thoughts?
Yeah, I agree that I think that telemedicine is here to stay. I think there's a lot of work that needs to be done in that space still, though, to understand. I think it's been fantastic. We've rapidly implemented it. I think there is a lot to understand where there's disparities, meaning is there Wi-Fi everywhere, broadband everywhere? Are our aging population actually using it? What kind of racial, ethnic disparities are there as well? And where does it work the best? So it might not work the best for the patient on active treatment, but for a survivor where you're assessing risk stratification, you're assessing toxicity from medications such as oral endocrine therapy, that may be a perfect place. I also think it's here to stay for some unique consultations. So let's say there is no cardio-oncology or no long-term follow-up survivorship expert, except for a 4-hour drive to the closest clinic for that. We've now been able to do e-consults that way and telehealth consults that I think that's there to stay.
Yeah, and I think that for survivorship, clearly there's never going to be enough bandwidth among us and even general cardiologists to do this, and even general oncologists, so that and even utilizing allied health professionals where we are or in our local area isn't going to be enough. And telemedicine here is like an amazing benefit from what we've experienced.
Yeah, I also think we have the opportunity to learn in some of those situations from our international colleagues. You know, this is a great venue to be talking about what's happening around the world. And as I mentioned, when you look at models of care like in England and Ireland and what Australia is trying to do, you know, they may not all work like that in the US, but I think we all can learn from each other when we're in conversation about self-management and engaging the patient. Exactly like you said, I think we really are going to need to think, just like you mentioned, Joerg, who's that high-risk population, both from a cardiovascular disease and an oncology perspective. We're going to be talking about that with survivors too.
And if I may ask, I mean, from your experience, and maybe it's just because it's the Minnesota population that we're seeing here, both of us in the north or in the south of the state, but do you feel that they embrace this this kind of technology approach? And I mean, patients are elderly, and I mean, sometimes, I mean, this thing, the iPhone, might not be what they're like as much. But do you see how, I mean, as far as these technical revolutions, do you think I mean, it's something they embrace, or is it a burden?
I think right now we see some of both is my honest answer about it. And I think that's where I mentioned to you trying to understand disparities. You know, we did some preliminary look, for example, when we rapidly implemented telehealth, and we were getting more telephone visits as opposed to video visits with our older patients, our rural patients, and our minorities. And there's a lot we still have to uncover with that. Does that affect care? You know, if I get to see you, does that mean you're going to get better care than if I talk to you on the phone? We don't know that yet. We also don't know what those barriers are, and will those get better as our older patients, for example, get more comfortable with technology. So I think there's some stuff we definitely need to, we have to understand, we have to continue to do research in this space. But I think at the same time, for some of our patients where it's not a 4-hour drive, they didn't have to take time off of work, they got to still see this specialist, they didn't have to find childcare. Those are all really tangible things. And you're exactly right, it might not be the right thing for the older patient who's hard of hearing and has neuropathy and can't use their phone and see you on their device, but it might work really well for the young patient who now didn't have to take time off of work and get childcare and got their consult.
And I add that, you know, that innovation always comes from disasters, so that we scratched the surface of telemedicine. And I would think that going forward, that we'll be able to listen to people's hearts and lungs, and somebody will be riding around with an echo machine with a butterfly or something, and we'll be able to get a lot of data to take care of patients remotely that we don't have today. So this is, whatever our impressions are today, has nothing to do with, I think, what it will be a year from now or 2 years from now.
Yeah, and I think it's really our job to work with collaborators, not just who we normally do. So thinking about, recently I had a conversation with a nephrologist from the University of Alabama. They have a very rural patient population, and they are using Bluetooth to download blood pressure. Well, patients on dialysis, understanding where blood pressures are at, medication management, you can really improve outcomes if I know where somebody's blood pressure is at. They're sitting at home and it's on my screen, right? So I think there are benefits, not just with telehealth and video visits, but other technology that we've been using.
So can I?
Well, so we have to finish because we have to move forward the next session. So thank you very much to all. We have understanding talks, and I say goodbye.
Well, hello again. This is Dan Lenahan. As you heard earlier, I'm at WashU in St. Louis. It's with absolute great pleasure that I get to summarize what's happened so far today. It's really been an amazing conference throughout, and I'm unbelievably astonished as to how our great friends in Madrid were able to successfully pull this off. So thank you so much to the organizers, and Teresa Lopez in particular, who has managed to pull off something that I really didn't think it was possible. So congratulations to all, and to our faculty and other people that have been very committed to this. We really thank you for all your efforts. Most importantly, the reason why we did this virtual meeting is, as you all know, because of COVID, really kind of messed us all up, and it continues to do that. But we're hoping that resolves itself in the near future. We were already planning on having our Global Cardio-oncology Summit in Toronto basically at this time. However, because of COVID, we switched to a virtual meeting, and Teresa did such a fantastic job. But what the decision that was made was to defer our meeting in Toronto until 2021. And so it's with great pleasure that I get to announce our hosts for our meeting in Toronto, which are our great Canadian colleagues, Dr. Dinesh Thavadantiranathan. I tried that to get it right. And Dr. Christine Brasden-Masley, who you've met both of them earlier in the program. And these are certainly some of our great international leaders. So I'm going to hand it off to Christine, who I believe is going to take the first part.
Great. Thank you so much, Dan. And I just want to echo what Dan said, is it's been a great day today. We really were looking forward to hosting the Global Cardio-oncology Summit in Toronto this year. And I'm really happy that Teresa was able to really pull it off and have this fantastic virtual meeting that has been truly outstanding with great presentations. So next year, we are really hoping that we will be able to host an in-person meeting. We'll certainly discuss whether or not we will move into a virtual format, but we are really hoping that we can host an in-person meeting. And it really will be September 30th and October 1st, but there will be a session on September 29th, of which Dinesh will talk about. So we're really excited. Toronto is a fantastic city. There is a lot to see and do. It is a world-class city. It's the biggest city in Canada. There is sightseeing, dining, and entertainment. And of course, the conference reception, that our dinner will be held at the famous Hockey Hall of Fame, which, you know, we can argue if it's a Canadian sport, but certainly it's going to be a fantastic evening that will be hosted on September 30th as our dinner venue. The conference venue itself will be at our historic Fairmont Royal York Hotel, which is in the heart of downtown. Toronto is actually walking distance to many fantastic attractions, such as the CN Tower is one. And of course, it's really accessible with a short commute to the Toronto International Airport and the other Island Toronto Airport. And of course, it's right across the street from our train terminal. So it's very accessible.
Perfect. Thank you, Christine. I'll continue on from here. Again, just wanted to thank the organizing committee for VCAUS for really hosting this and doing a superb job. I think it was a really nice, concise, and well-designed program that hit really the major issues in the field of cardio-oncology. Very practical, a lot of take-home points. So thank you for the organizers, as well as thank you to everybody who provided really wonderful talks in the field that were very practical. So from a 2021 GCOS perspective, as Christine mentioned, we had worked on a program. We had a scientific committee, some of the leaders in the field of cardio-oncology who came together to come up with a fantastic program, and the list of the scientific committee that was involved in the design of 2020 will continue on for the 2021 meeting with potential addition of others are shown on this slide. So just what's on our program. So we have sessions that cover a broad spectrum of topics. This includes topics in hematology, clonal hematopoiesis and its impact on cardiovascular disease and as a shared risk factor, radiation-induced heart disease, concepts that relate to survivorship, early diagnostics, arrhythmias, thrombosis, some of the current research in the field, both clinical and lab science, as well as, of course, adding COVID-19 related topics in the presentations as well, and many more that I'm unable to cover in detail here. So a very broad program that covers the entire spectrum of cardio-oncology within the time allocated to us. As Christine mentioned, we had also planned on having a hands-on session in echocardiography and cardiac MRI the day before. And I think this speaks to many of the issues that were brought up today related to reproducibility of some of the measures within the cardio-oncology community. So we thought we'll take the opportunity to bring those people who are interested the day before and provide opportunities for image acquisition, and post-processing with some of the leaders in the field from across the world in an attempt to hopefully standardize acquisition and analysis with the eventual hope that this may help reproducibility of these measurements and perhaps more robust clinical application of these techniques in the field of cardio-oncology. We are hoping that we'll have call for abstracts in early 2021. We hope to open registration in spring 2021, and the website is provided there. And of course, we'll be working very closely with ICOS together to ensure that this meeting is a success. And information will be updated at the ICOS website as well as the website that's provided at the bottom. So keep looking at the site for updates in the area, and you probably get emails from ICOS providing updates on the progress with respect to the program.
So we hope to see you all in Toronto, Canada for GCOS 2021. This is a picture of my sailboat. As you can see, we do a lot of fun things in Toronto, and we really look forward to welcoming you next September, October for GCOS 2021.
Super. Thank you all, Dinesh and Christine, particularly for taking on this responsibility for such a complex meeting. We really appreciate it, and we can't wait to go. I do think that a couple of items that were brought up during the meeting that I would just want to emphasize, that there are satellite sessions with a focus on echo imaging and a focus on cardiac MRI imaging in cardio-oncology. And then also there have been questions about further training, and we have created a board certification test in cardio-oncology, which can be found on the ICOS website. And there's also a board review manual that was just finished and has been published today. So thank you for all for your interest internationally, and we look forward to partnering with you in many different venues going forward. Thank you very much.